and see your presentation. Maybe want to start.
Thank you, Dr. Michael, and nice to see all my friends here. I missed last year Shanghai.
Yeah, I know. We missed you as well. Okay. Can audience in Zoom see Dr. Prema's presentation? Yes, perfect. Okay, let's just see if we can get it properly.
So before that, I'll introduce myself. I'm Dr. Kannan Prema. I'm a plastic surgeon. I do regenerative medicine and cosmetic surgeries. I come from India and I'm associated with the Keloid Research Foundation with Dr. Michael last 10 years.
10 years now. Yeah.
10 years. Time is running really fast. Dr. John, Dr. Henry, hi. Yeah.
You can use the mouse and click on this. That will go to the next presentation. Okay.
Yeah.
There you go.
Thank you.
I'll be your AV technician as well.
Back home, I work with the largest corporate hospital in Asia. It's called Apollo Hospitals. I'm a consultant plastic surgeon there. I work with Apollo last 16 years, and I'm a consultant there last 9 years, 10 years. Yeah. So thank you for accepting my presentation and giving me an opportunity to present this. And everybody is presenting their research and clinical work. So what I thought was, let me dive into how did this keloid come first and who diagnosed these keloids in the ancient times and from where the treatment started and what is the current treatment done. So this is purely based on multiple journals, and it really took 2 months. My team entirely went through so many journals and they picked up points and they gave me, and I had to compile them. So it was really, really fascinating, and I have a lot of learning with this. I'm really thankful to myself for choosing this topic. So coming to the global prevalence, it is 2 to 4%, and African descent has the highest prevalence, whereas Asian and Caucasian, not major difference. It is lesser compared to the Africans. Keloid is a tumor of the skin. It has no metastasis, but it is a locally aggressive invading tumor into the surrounding healthy tissues. And Dr. Michael said, don't talk about keloid, but I just wanted to say it is definitely not a scar, it's a tumor with no metastasis, but it invades the surrounding healthy tissues. The thing is, this does not regress spontaneously, so it definitely requires attention. Age is 10 to 30 years is common, very rare in young and elderly, but I did see pics of Dr. Michael with 6 years and 80 years. Yes. And gender, technically, there is no significant difference, but female is slightly on the higher side, maybe because of the ear piercing. And there's also a study saying estrogen can also be a reason. I don't know how far it is because I didn't go through that completely. But I do agree with ear piercing because all girls, all women, we like to have nice earrings. So that also has higher predominance compared to the men. And coming to the main slide, historical background. So I've divided into multiple subheadings, Asian medicine and earliest documentation. So Edwin Smith's papyrus in 1650 BCE. So this BCE and CE, I mean, as I said, I had a lot of learning while doing this. So I remember BC AD. So then I went through what is BCE, what CE, and that was also learning for me. And he was mainly handling the wounds, healing the wounds. And when the wounds are not properly healed or properly dressed, or when it is infected, it leads to abnormal dermal growths. So this was first diagnosed in 1650 by Edwin Smith. Egyptians' technique of bandaging was to use honey as antibacterial. lint for absorption. It absorbs very well. And grease was used as a barrier. Next is Sushruta Samhita from my country, India. In 600 BCE, he is also called father of surgery. Those days, the surgery, popular surgery, was Ayurvedic surgery. So herbs were used for treatment, and he was also a cutting doctor. So the procedure performed was called Sahalya Tantra, which means it's a surgical intervention using Ayurveda, where he treated orthopedic conditions as well as wound-related conditions. He used different plants, and they have some 100 names of the plants. And this treatment was described as Ashwida Sashtra Karma, which and failure of healing the wound is called Pakavasta. Pakavasta means side effect. So Pakavasta, failure to heal will cause pus and pain. So this was considered a failure, and with this Pakavasta will lead to tumor-like conditions in certain kinds of wounds, which was not described exactly as keloids. They said if the wound healing is not adequate with Pakavasta, it causes abnormal scars, the abnormal tumor-like. Coming to Greek physician Hippocrates, who's the father of medicine, he used vinegar and emphasized on proper wrapping of the wounds to prevent abnormal wound healing. So abnormal wound healing will land up in tumor-like conditions. The Asian medicine continued. Chinese document, I couldn't get more, please forgive me. And what I went through was they described as tumors caused due to residual toxins, damp heat, and QE blood stagnation. Okay. And herbs used were, these herbs were also used in modern Chinese medicines for a treatment of keloids. So, Danshan, forgive me for my spelling and my pronunciation. Danshan, Cushion, all these Gala Chinensis, and these names as you see. Is there a point? Yeah. Is there a pointer with this? There comes a pointer with this, right? Yeah, laser pointer. Yeah. Laser pointer. Man. Yeah. Fine.
There's no pointer. The Zoom audience see that.
Yeah. This comes.
Okay.
Yeah. So Asian Chinese medicine typically works with herbal framework. So Chinese, Japanese, Indians, we all three predominantly believe in herbal natural medicine, and that works for most of the diseases in our zone. So Chinese have also done herbal treatment for tumor-like conditions. Again with the Asian medicine, Gallian, he's a Roman surgeon, he observed that there should be pus in the wound. So this gladiatorial wounds preceded healing with pus. So when there is a pus, it indicated that it is an inflammatory phase. So when there is an inflammatory phase, the wound will be better. So this was their observation in 129 to 129 to 216 CE. So then coming to the 19th and 21st century, there was a transition from this mystical to systematic understanding in early 19th century. 19th and early 20th centuries, the understanding was towards histopathological characterization. Mid to late 20th century, research shifted to biochemical and cellular level. In 1806, French dermatologist Baron Jean and Louis Alibert termed cancroid. This is to emphasize invasive crab-like growth of the scars. In 1816, again, Albert, he defined the term keloid, which is a Greek name. As you see, keloid means crab claws. In 1919, plastic surgeon John Davis described early treatment modalities, predominantly surgery, he described excision and closure, excision and skin grafting, partial gradual excision, radiation, injections with mixture of fibrinolysis and freezing with carbon dioxide. And this era marked the beginning of recognizing keloid as a proliferative disorder that requires more than simple surgical removal. So simple surgery is going to give 100% recurrence over a period of time. So the combination or cocktail treatment is the best. Introduction of intralesional corticosteroids in 1950 was a game changer. Along with development of cryotherapy, this helped to suppress the overactive fibroblast response. In 21st century, the focus was on genetic predisposition and aberrant fibroblastic activity, making keloids as a chronic inflammatory fibrotic disease rather than just a cosmetic concern. I think this point can be given to the insurance, I believe. So coming to the again the historical background. So this pathophysiology is divided it has subdivisions. The first subdivision is cellular mechanism and fibroblast heterogeneity. So the central orchestra of pathological scarring is keloid fibroblasts. So this has four types of fibroblasts, that is inflammatory, matrix producing, contractile, and proliferative. Inflammatory fibroblasts are localized along the periphery of the keloid, that is the active growing margins, and expresses high level of pro-inflammatory cytokines, interleukin 6, this CCL2 and CXCL12. Forgive me for all these names, I'm not very great in pronouncing all that. I'm more of a clinician, but I took a lot of effort to do this, and please bear with me. And the main aim of them is, this maintains the chronic inflammatory state, that is, this interleukins and these inflammatory markers maintains the inflammatory state, and then it attracts further immune cells. This matrix producing fibroblast, they are concentrated in the center, and this is the stable region of the keloids. And this is characterized by elevation of the call 1A1 and call 3A1 and fibronectin expression. So this activation makes deposition of excess collagen. Contractile myofibroblasts, these cells are can we switch off this thing? This screen disturbance. Yeah. So contractile myofibroblasts express alpha smooth muscle actin along the tension lines. So this aggravates the physical contracture and rigidity of the keloids. Then comes the proliferative fibroblast. These have increased expression of these two genes, that is Ki6, these two markers, and this is distributed throughout the lesion. So this facilitates expansion. So inflammatory fibroblast is at the periphery, matrix is at the center, and myofibroblast helps in contraction, and proliferative helps in expansion. Then comes again the cellular mechanism, pathophysiology. This keloid fibroblasts has a migratory behavior, and this moves towards the wound 50% with greater velocity than the normal dermal fibroblasts. This is supported by upregulation of matrix metalloproteinases 2 and 9, and increased expression of this integrins and alpha beta 1. And this keloid fibroblast has a metabolic reprogramming similar to the cancer effect, which is called Warburg effect. And this is characterized by enhanced glycolysis and altered lipid metabolism. So this supports high biosynthetic demands. The next subdivision in pathophysiology is molecular pathways. So the growth and maintenance of keloid has a self-reinforcing loop. which is supported by this transforming growth factor beta and SMAD signaling. So keloid tissues have 3 times more this transforming growth factor beta compared to normal skin. And this elevated signal drives collagen production through phosphorylation of SMAD2 and SMAD3. Again, the molecular subdivision, molecular pathways and pathophysiology, interleukin 6 and tumor necrosis factor alpha compared the keratinocytes in keloid tissue has more expression of this interleukin 6 and TNF alpha, and this helps in more fibroblast production. Not help, it actually aggravates. Then comes the vascular endothelial growth factor. This increases the vascularity of the keloids by 50% more expressions. And this VGF also creates an autocrine loop that helps in survival of the fibroblasts. Next comes the WNT beta catenin pathway, and this prevents apoptosis in keloid fibroblasts. Then the other subdivision of this pathophysiology is mechanical tension and the invention of this piezo O2. And what I read from the literature is this was discovered by Professor Yuzuru Ikira. I'm sure this professor, found out this into 2025. I hope we also invite this professor for the meeting. And his discovery has been a game changer. This shows that this is a mechanosensitive ion channel, and it is found in keloid tissues, and its higher expression opens the channel and causes this keloid to grow. So, yeah. Next is genetic and epigenetic influence. In genetic, the susceptible loci is in all these chromosome areas, as you see. And there are syndromic associations also. And epigenetic is basically the modification in the histone, that is the H3K27ME3, and non-coding RNA with this. I'm sorry, I'm not going to read all this. I'm sure I'll be boring by reading all this with the great researchers here. So, their dysregulation in keloid led to abnormal activation and collagen synthesis. Now, coming to the evolution of treatment, early and primitive. First, I want to talk about the early and primitive one. In Egyptian era, the Egyptians used honey as a wound treatment. In ancient Greece, Hippocrates used vinegar irrigation to prevent infection. And 19th century, carbon dioxide, snow, and surgical excision were common, but they frequently led to worse recurrence. Surgical error. In surgical error, it is the most common treatment for significant number of keloid lesions, yet used alone, it is profoundly ineffective and causes 100% recurrence. So effectiveness as a monotherapy has 45 to 100% recurrence. In my cases, I've seen 100% recurrence as a surgery as a monotherapy. And though I used reducing the tension line, the flap, and all those things, but it had 100% recurrence. Now, recently I did 2 patients with the dermal matrix. I removed the chest keloids and I put dermal matrix, and last 6 months I didn't find any recurrence. Maybe I need some more time to see how it works. So the radiation and pressure therapy era, the radiation therapy are X-ray and electrobeam radiation. It works by arresting the cell cycle and inducing premature cellular senescence. And effectiveness is when it is used more than... Yeah. So effectiveness is more when it is used more than 30 gray, and recurrence rate is reduced less than 10%. One clinical evidence by Chilean study showed that the recurrence rate was 32% using 15 gray in 3 fractions, with no further recurrence after 15 months. Pressure therapy was very effective for ear keloids. It induced apoptosis of the cells and pressure-induced ischemia that alters the fibroblast activity, and it prevents, maybe it stops its becoming bigger. Recurrence rate was reduced when used on the ear keloids because it's more comfortable using the pressure buttons on the ear. Again, in the pharmacological era, there are few corticosteroids, 5-FU, bleomycin, and interferons which were used. Corticosteroids, the popularly used one is triamcinolone, which is used by all of us, and this had very good effect, suppressing wound inflammation mediators and fibroblast growth while increasing the collagen degradation. As a monotherapy, this had 50 to 100% result, whereas the recurrence rate was 20 to 30%, which rises to 50% after 5 years. Means this triam injection definitely gives a result at that time, but this has to be supported with massage and silicone gel sheets over a period of time to keep it at bay. Otherwise, what happens is when the patient is going to scratch, it is again going to come back. Maybe not as big as before, maybe definitely 50%. 5-FU seems to have a good effect, and a combination of Triam with the 5-FU yields greater clinical outcomes. And it can be used with the larger keloids, maybe more than 10 centimeters or 15 centimeters. Very good. Bleomycin is not used because of susceptibility to human it has a carcinogenic effect, so it was not used. The interferons alpha, beta, and gamma have reduced collagen production, but the results are being scattered and inconsistent among researchers. In modern therapies, laser and cryo was used. So these are energy-based device, and laser therapy was YAG, CO2, and PDL. So the mechanism was photothermolysis of blood vessels and ablative remodeling of collagen. And this, when combined with triamcinolone, it has a lower recurrence rate of 12.2%. Cryotherapy caused thermal shock, and intralesional cryotherapy, it destroyed tissues from within with a decrease in keloid scar size, and this is associated with minimal dermal surface injury. Silicone gel sheets, yes, it increases the hydration and reduces growth factors in the scar. And there is a study in one paper saying that it will help to suppress the TGF growth factor. Next comes the advanced and emerging therapies. The current research is focused on molecular and genetic roots of the disease. So RNA-based therapy, the mechanism is silencing certain specific genes involved in fibrosis, like these one, and LEMS401. This one and the STP705 are in trials, phase 1 and phase 2 trials, which is used as a genetic therapy to silence these keloids and reduce the size. Next comes the stem cell therapy, which is my domain, which I'm planning to try this method. And it is adipose-derived stem cells. Do liposuction, take the fat, convert that fat into nanofat, and that nanofat we derive ADSC. And this seems to modulate the immune response and reduce fibroblast proliferation. ADC has a promising potential in reducing collagen deposition, proliferation, and migration rates of fibroblast. I think as plastic surgeon, I'm planning to do this definitely. In advanced and emerging therapy, molecular targeted therapy, as Dr. Michael said, this has not much effect, and that is what that's what the people have also said, but so I have mentioned here. So this monoclonal antibody targets interleukin-4, interleukin-13, and STAT6 pathway, represents as a promising therapeutic strategy, but it needs more study. Next is tissue engineering. Hydrogel scaffolds infused with stem cells and growth factors create a moist environment that promotes healing. Current management guidelines, while there are no standard universal guidelines and still under development, the current guidelines, as mentioned in one of the journal I've copied here, surgical intervention is radical resection of large tumors with core excision for ear keloids, along with adjuvant therapy, which should be done within 24 hours of the surgical procedure. The common regimen followed is 15 gray in 3 fractions. Pharmacological maintenance was after excision, the site is often rinsed with glucocorticoid, that is Triam and 5FU together. Recurring patients may receive 3 to 5 monthly injections of mixture of 10 mg Triam and 25 mg per ml 5FU. Long-term prevention, topical silicone medications like gel set sheets used for 6 months following wound healing. Future directions, the field is moving towards precision diagnostic markers and mechanism-based therapies. So mechanosensory targeting, that is piezo-O2 inhibitors, which is a type of calcium ion channel blocker. This helps to elevate pain and itching and prevent tension-induced overgrowth. And there may be future medicine on blocking this calcium channel ion, and it can help in treatment of keloids. Regenerative pharmacology exploring ethyl pyruvate. This shows decreased in collagen synthesis and upregulate MMF in keloid fibroblasts. And RNA medicine, thanks to COVID, because of COVID, we started developing good mRNA vaccines. And there is research going on making novel RNA drugs for this keloid disease. To conclude, it's a modern inflammatory disease, not a cosmetic one. And this is driven by complex interplay of genetic predisposition, mechanical tension, and persistent cellular activation. The ancient observation of Smith Papyrus to 19th century nosology of Baron Alibert to 21st century Dr. Michael Trigan. The medical journey has been one of the interesting and increasing biological granularity to bring solution to the keloid patients over a period of time with the like-minded people of like us in this auditorium. And I'm sure we are going to help those patients because we see them suffer a lot, a really lot. In my part of the country, I don't get big keloids as shown by Dr. Michael and some of my colleagues. We see about only the size of the keloid is about less than 10%, but that itself is very disturbing to our patients. So that is what made me join this research foundation to help our patients. And yes, together, I think we can make a difference in these people. And I'm sure with so much of genetic research come, I'm sure we'll get some injections we put or we put some tablet, it's going to manage something like that. Some magic is going to happen in future. I'm very confident about that. Yeah. Thank you.